This is actually the first part of the last lectures that we're going to give. Both of them have to do with capacity. On next week, I can't remember if it's Tuesday or Thursday, we'll deal with capacity in terms of mental illnesses and such. Today, we're going to look more at the general understanding of capacity, comparing it with competency. We will look at the criteria, the components of capacity, and then kind of like, push it towards like what exactly would a nurse have to do with this. And I'll probably treat that like an emergency room because that might be a situation. I mean, typically a nurse's role in capacity has to do with like advisory and observation and such. So you play an active role, but not a determinative role. Okay, so that being said, then other than that, this Thursday is our presentations. And then we have one more group and then one more presentation. So this is the second to last lecture. Now, in the same way that privacy and confidentiality had similarities, but privacy was more of a legal issue based on personal dignity, you're going to see that same sort of distinction here with competency and capacity. So competency is something that is determined particularly by a judge, right? So this is a legal determination, and the person will be found legally to not be able to make decisions on their own, and either a family member, an advocate, or a surrogate, even be the hospitalist and such, will be placed in their stead. We're not dealing so much with capacity. We'll talk a little bit about it, but that's a legal issue. Typically, what medical health field will deal with hands-on is capacity. Capacity differs because this, first of all, is going to be very minimal. What it takes to determine a person has capacity is a low threshold. And there's reasons for that. It's to protect their autonomy. So we're going to have the same sort of, you want to say, issues ethically, at least with our consciences, between how far do we go with, patient autonomy and beneficence. So we're still going to struggle trying to find a way to balance those two things. But this is going to be a purely functional assessment. So DMC, I'm just using it as an acronym as decision-making capacity. This is going to be something that a clinician determines. And by clinician, it's going to be a physician, a registered psychologist, or perhaps even a nurse practitioner, depending on the region and state. So the difference generally between these, besides the fact that competency is a legal determination, capacity is something that is not static. Competency is static. The person's been deemed incompetent. A surrogate will be put in place. Capacity, we're going to see, there could be times when a person loses capacity and then gains it back. And there's going to be different criteria that comes into play to determine exactly what level they are. So this is not a light switch that you turn off and on, that a person has capacity, doesn't have capacity. It's not going to be fluid, perhaps from hour to hour. But if you want to just real generally think of an individual, perhaps brought into an emergency room, maybe with they're concussed, and they could be at sometimes very lucid in explaining who they are, where they are, all of those things, and then maybe a half hour later, not so sure. Now that you don't call capacity, with every 30 minutes, but nonetheless, it just gives an example that if this is going to fluctuate, or a person perhaps that is under the influence of a drug or alcohol, they would lack capacity for a certain point, and then they would gain that back as time goes on. So all of these things are going to be factors that we're going to consider as we move along. Before we get into talking about the components of capacity, though, I want to talk about a landmark case, because oftentimes you're going to find that these components, and I'll reiterate this, the components that are used to determine capacity, they are what we would call not produced, they are associated by custom. There's a better way to say that. Approved by custom, that's the term. So in other words, it's been experienced over time, like how do we deal with certain things in terms of capacity, but they're also affected by legal cases and court rulings. So all those things together have helped determine what the components are. And what I want to do is I want to look at one case in particular, the Lane v. Condora case. Anybody want to share with me? Did you read the blue box on this? Any general understandings of what this case entailed? Okay. I'll try to give you a rundown. First off, so you have a woman, Mrs. Condora. She's a widower. She generally enjoys life, but she's, lost her husband and, and loves her children and grandchildren and such. And is presented to the hospital with uh, a sore on her toe, and it's then found out that she gangrene on the toe and she's diabetic. So she's they're telling her situation and asking for her consent, and she consents to have her toe amputated. It progresses a little bit, and eventually there's a larger part of her foot that becomes affected. And they explain to her that that's larger part of the foot has to now be amputated, and she consents to that. And I can't. It's been a little while since I read the actual case, but if I remember right, I think she injured herself getting into a car, perhaps. Nonetheless, she bruised her leg, and that then became an incident where it required amputation. She agreed in the beginning and said, "Okay, fine," and then she pulled back and said, "No, I don't think I want this." And she realized that you know this diabetes would progress and it would eventually lead to death, and that amputation would at least stave off the progress of the disease. But she went back and forth on this for a while. She agreed and then brought back her consent and consented again. And it got to the one point where she consented, and actually the day of the surgery, she withdrew her consent. So you're starting to see her, uh, vacillate back and forth, and the physicians are getting a little concerned. So they start to question her capacity. And when they ask her questions about why she doesn't want this amputation, she seems to get that it's tied into a progression of a disease that will lead to her death. She seems to be okay with that. She doesn't want to be a burden to her children. That seems to be a very big factor for her. Um, when they ask her, like, well, why did you pull back on this? She gives a rationale for it. And she says, well, the reality is that the last two amputations I had did not stop the progression of the disease. So, with most things in this scenario, the medical team can't give her 100% certainty that nothing's going to not progress even after this. So, with that being said, she thinks it's going to be a higher level of disability for herself, that she's going to wind up being a burden on her children. She just makes a determination that I don't want to have this amputation. And she realizes that this will lead to death. Okay, so this then starts the process where they are going to pursue, they're deeming her lacking mental capacity, and they're going now to go after courts to get a legal finding in their favor so that they can force her into this amputation and thus preserve her life. So, right, you're always in this situation where you're trying to balance patient autonomy and beneficence. So a lower court actually went in the hospital's favor and said that you can go ahead and amputate this. But an appeal to a larger, higher court actually found in her favor and refused in the end to actually give her any sort of surrogate. Now, interestingly enough, the reason why, now I'm not a legal expert, right? So I'm not trying to play lawyer here, but reading the findings, what the judge determined was that, interestingly enough, they never questioned Miss Condora's uh, lack of capacity until it didn't fall in line with what they thought was rationally medically necessary. So, that was the court's concern. Well, why did you not question her capacity when she consented the first time? Why did you not question her capacity when she consented the second time? It seems to me that the minute she went against what you thought was the rational medical advice, and all of a sudden now you're calling her, lacking capacity. So that was one of their concerns, right? Because remember, this case, one of the findings that we're going to see from this is that it set the threshold very low. It really puts the ball in the court of the patient. Even when it seems like, from an ethical standpoint, like, come on, this is a reasonable procedure to have in order to extend your life and your health. But another issue that they had was they didn't really think that the judge didn't really think that the hospital lawyers had sufficient evidence for her diminished capacity. In other words, what criteria are you using? In essence, all they're really saying is that you think her decision is irrational, and they didn't think that was sufficient enough. So their finding was, we refuse to appoint a guardian, for Mrs. Condora, and she can withhold the amputation and accept spread of the disease and the ultimate lack of health and death. Um, Now, interestingly enough, through all of this, and the reason why this is important is because it really makes the determination for capacity one based on functional assessment, not based on the medical rationality of the procedure. So if this was my father or mother or my grandmother, I would be on the side of the hospital. This is a reasonable thing to do. But on the other hand, we struggle as a community to deal with patient autonomy. And if you're going to declare somebody incapacitated, in other words, they cannot make any medical determinations like that, think of what that does to a person's autonomy. I mean, that takes everything out of their hand and places it into the either this could be medical paternalism again, or if it goes into one of the relatives, then we have the same issues of consent. We have the same issues as we did with consent, right? Are there ulterior motives? Do they have the best interest in view of this patient? All these other things start to crop up. Now, I'm not a lawyer, but it's curious that why they found that they didn't have sufficient evidence and what would have been sufficient evidence. That'd be an interesting thing to ask a malpractice attorney. If they would have pursued, say, psychological analysis before this, when the psychologist signed on to this, saying that there's, they can pretty much lay it out medically exactly why they think there's a legal concern here for capacity. And if that were presented, I mean, it could be that the judge simply agreed, but just said, legally speaking, there's nothing here that we can do, that type of thing. So this set the threshold very low. And again, as we look into the components, which we'll do here in a minute, those components are going to be based off a lot of these various court findings. And it doesn't matter what state these are in. Even if they're not legally binding in a particular state, they're still very influential. And they set the tone for how medicine is going to be practiced, particularly in terms of competency and capacity. Now, one last thing before I ask if there's any questions on this is, let's say that she was deemed to be incompetent and she could not make these determinations on her own. And a surrogate or maybe the hospitalist was brought in to make these decisions for her. Is it still ethical to move forward on this? Now, these two physicians, Prager and Rubin. Rubin, I think, is a second-year intern. Well, he should be done now. But in 2018, so think of, we're only in 2020. So in 2018, the intern did a literature research, find out, like, what are the guidelines for physicians when it comes time to make somebody go against a treatment they're doing a treatment against their will because they've been determined, lacking capacity. And what he found was there was almost absolute silence. There was a few things out there, but there was really nothing across the board in as far as what you want to call the guidelines, which means that this was pretty much left up to what they would call ethical intuitionism, right? Now, that's not just what I think is best, but it could be that. So Prager, who was one of the physicians, I think he said he had 300 different cases that he was involved with ethically. Now, that's a pretty high level of intuition, but that person's intuition is not going to be the same as somebody else that doesn't have that kind of exposure to various ethical cases in the medical field. Even if they are physicians, that's not enough. So what they did is they tried to develop certain guidelines to at least help. But this is extraordinary that we're talking 2018 before these types of guidelines start to appear. So I'm not going to go through them, but I want to give you at least two. And they're things to consider ethically. So even if you force somebody into what we would deem a rational medical procedure, what sort of psychological harm is it going to do the individual? I mean, could you imagine if somebody was forcing you to doing a procedure or getting a treatment against your wishes and your desires, even because they've deemed you lacking capacity? How this has to affect a person, their personhood and their own autonomy. They're going to really feel like their dignity has been compromised. We can at least say that. So you have to consider that. This doesn't, again, even if the person is incapacitated mentally, there's still other considerations ethically before you move forward. And the other thing is how do you make somebody comply with treatment? even in the case of Kandura, you could say, well, she's in the hospital. It's enough that, amputate her leg, should be under sedation and such. But, she is going to have to basically have maybe at least months ahead of physical therapy. It's unlikely that they'll have a prosthesis, but nonetheless, she's going to need some sort of physical therapy care and people that are going to have to be surrounding her for support. Well, if she's already very much concerned about being a burden to her children, this is just another element that's thrown into the mix. Now she's going to be a burden to her children, and she has the psychological effect of her being forced into a treatment and a procedure that she doesn't want. So these things, these are just two. They must have had like 5 or 6 various things they came up with. But I thought these were 2 interesting ones. So even we're trying to determine capacity for an individual, and we'll look exactly what that entails. Even once the person has been deemed that they don't have decision-making capacity, there's still ethical concerns that you have with moving forward. They're not easy. And there's going to be a lot of circumstances, and it's going to be very dynamic trying to determine those. But nonetheless, any general questions just on the basic distinctions, the Kandura case, any of those? All right. Just holler if they do. Okay. Now, before we look at the components, and the components in the book, I think I got them pretty close. One of mine might be named differently, but it's the same thing. When we talk about these things as components, most often in academics, we systematically study things, right? So we study them in their parts. And the danger of that is to think that these parts are parts and somehow they're not interconnected. And then when we see a connection, sometimes we wonder if we're talking about 2 different things or the same thing. So we're going to have to realize here that this is not like 4 columns. When I give you understanding, comprehension, and various components, you're going to wonder, well, that sounds a little bit like the one before it. Yes, it does. There's ways we can talk about them differently just for the sake of analyzing them, but it's probably better to understand this as facets. Like think of a light going through a crystal, right? We would not say that, one facet is that distinct from the other, because the way they refract, they all, in a sense, affect each other. So anyway, the first one is understanding. Now, when a person gets a prognosis, various news, there's going to be some determination as to like, do they have a full grasp of what lies ahead? Whatever it is that their disease is, that they get that the procedure is connected to the disease they have. Do they understand that fully? Do they understand that whatever procedure that's being requested or being suggested, that it's going to have risk and it's also going to have benefits per se? This gets very difficult sometimes to make certain of. But remember, the threshold's very low here. If you want a way to really grasp what this means is, if you can get a patient to repeat back to you in their own words, then you realize they understand it. So if the physician was trying to explain a procedure, and maybe the procedure doesn't have to be very complex, but it could be complex to the individual, and if the individual just kind of parrots back what they heard, that's not sufficient. In other words, I'm not quite sure you understand. I want to make sure you understand. Can you give it back to me in your own words? Now, the problem here is that understanding is not directly tied to a person's intelligence. Terms can be very technical, right? So as you guys move on in your careers, you're going to be very adept in using the lingo within your field. And that can be intimidating to those people on the outside, right? So I get this all the time in philosophy. You can go off into a rant pretty quickly and lose somebody. So it's not hard for somebody to do, so especially, and again, nothing with intelligence. It could be that the person doesn't really like grasp the whole idea. They've kind of been like, outside on this and let somebody else make decisions for them because they trust their physician. And now it's required to determine whether or not they have particular capacity, and understanding is trying to be determined. So the best way, again, to understand, just reiterating, the best way to realize that they understand it is, are they getting it back to you in their own words? If they do that, then at least you have a reasonable understanding of things. Yeah, they get this, all right? So that's one of the things you look at. But you're going to see it's not entirely distinct from appreciation. So if somebody gets some very bad news, it would not be odd for that person to go into denial. And if a person's in denial, in other words, you tell them they have X amount of time to live, and next thing you know, they're talking to you about going to Europe on vacation next summer, and you're thinking, you get what's going on here, right? you're trying to say, can you appreciate the gravity of the situation? So I remember with my mother at one point when they were determining what to do, it was towards the end of her life, perhaps with not withhold any treatment, remove the port, and you'd have about 2 or 3 weeks to live, go home and be comfortable. And my mother was like, she's always very polite and very responsive to authority. All she said was, "Thank you, doctor. I'm glad you told me that." Well, that didn't quite seem a response that convinced me that she understood it. And I didn't want to just pretend that she was unintelligent or made her feel stupid and say, "Mom, did you hear what they said?" But I tried to find a way. I said, "Mom, what do you think about it? How does that make you feel?" I was trying to find ways to do they appreciate what's going on? Remember one time I had a cousin that was in a hospice, and he was at the point where we're talking a day, maybe two at most. I remember his mother grabbing the nurse and saying, "Is there any hope for him?" The nurse said to me, "Does she understand?" Now, this isn't the patient, this is a patient's family. But if somebody starts to talk in a context like that, you're going to be very concerned that they don't appreciate the full gravity of what exactly they're in the middle of, right? Um, so you have to be able to engage in something that's, consequential and comparative reasoning. So whatever you can do to get a feel for the appreciate it. Because remember, the call for capacity is going to be with the physician, perhaps the hospitalist, a licensed psychiatrist, or maybe a practitioner. But that doesn't mean that you're not there to advocate and absolutely not there to observe, perhaps even advise, if the doctor asks questions that. So this all becomes part of that. And we'll talk at the very end of this, like the person, place, and time, what they call AO times 3. Okay, so reasoning, now this is something that, again, it has nothing to do with intelligence, but it could, right? So a person has a lower level of mental capacity is certainly going to fall into this. But it could also be people who are, say, intoxicated. They lack the reasoning abilities at the time. Or it could be a person, like if you ever dealt with anybody who takes illegal drugs or anything that alters, the mental state. There's one level of responses when they're in their, high state, and then the withdrawal also affects reasoning. So that's all something you're gonna have to interpret. If a person comes in concussed, right? I mean, I remember I I literally have had 5 concussions and a hairline fracture. It's a wonder I can tie my shoes, I guess. But I remember I woke up in the ambulance right in front of the hospital. And there were times where I was extremely lucid and I could have explained anything. I mean, I could have gave it the definition of a hiccup. I mean, you tell me, right? Um, and then maybe a half hour later, I wasn't quite sure, that type of thing. Now, even though a capacity is not going to be determined by every 30 minutes, those things could always affect a person's capacity. So anxiety, um, hospital delirium, it could be a phobia the person has, right? So remember we did the one case study about in Chinese how the word for and death are so close. Hospital right near me where an individual did not want to go into the fourth floor for surgery because they thought that was superstitious. Okay, we might call that a phobia. That's the cultural sensitivity course class, you remember. But that could affect a person's reasoning ability, right? So there's nothing to do with intelligence levels. But you're going to have to work through those things and determine this is just part of it, right? So you can see how this is how this is associated with understanding and comprehension. Then the last one is communication. I think they called it in the book expression of choice or one of these two. I can't remember exactly what it was. But this would be like, this could be if the person's going back and forth, right? Now, the difference is that if a person is ambivalent over what to do over the course of days, that's not the same as a person changing their mind. So in the case of Condora, she changed her mind by assenting and then withdrawing her consent, but she was able to build the rationale why she did it, right? Even if it was an emotional excuse. When they said, "Why are you now, lacking, or why are you now withdrawing your consent for the amputation?" She goes, "Because I do not want to be a burden to my family." Okay, a person that starts talking like that, according to the low level threshold, that's probably going to tell you that this individual, at least in this particular case, under communication, they understand what's going on, right? This isn't the same as being in some sort of like clinical stalemate, I guess you could say. So there's no switch, right? Capacity is not an on and off thing. It's on a spectrum, and all of these things have to be incorporated into your evaluation, but they're all, again, part of an overall construct. So, it's not going to be your call, but as an advisory and an observer, the doctors and the clinician, whoever's going to be making the calls, they're going to use all of these factors to try to have some determination on capacity. And the reason why this is so serious and the threshold is so low is because, again, can you imagine taking away determining factors of individuals and no longer giving them an opportunity to make choice? Like, do you have any questions? Something I want to say on that. Do you have any questions? When you, especially like okay, so everybody's in lockdown, right? And it's very easy for us to kind of get disoriented in our days, unless you have a very strict routine. Well, you can only imagine what it's like when you're in a hospital, right? Or how about this? You can only imagine what it's like when you're nursing home. So in the nursing home, these people, like I know my wife is still going in 3 nights a week, and they don't call it assisted living, but it's sort of like that. Those individuals still are able to come out of the rooms. They're only allowed to be in groups of 4, and they have to be 6 feet apart. But the nursing side, they're all in lockdown. Well, they can't have family members come over. The only way they have any visitors is people go up to their windows on the outside, and that's if you're on the first floor. Unfortunately, the people with dementia and such are on the second floor. They can't even be visited. So it's very easy, and when you're when you're in the hospital, it's very easy to get disoriented and such. All those things have to be taken into consideration. But it's the reason why, and this is where I was going with this, the reason why capacity has such a low threshold is because the dignity of the human person. As you get older, you're going to find out that your ability to make choices gets diminished. And at some level, it's going to get to the point where you don't have a lot of choices to make, they're being made for you. That's not an easy thing, especially if you're a very independent person. So like my mother, who basically lived in the same house for like 90 years, right? We finally moved her in with us. She would get to the point where like we'd get up in the morning, and I'll share this with you because I'm a huge advocate as we move on to this and we start talking about the scenario in our case study today. I don't push this on anybody else, but I'm a big advocate for taking care of parents the best you can. If they need round the clock nursing care, you can't do that. Or if they need a level of nursing care that you can't provide to them, well, then there's nothing else you can do. Be nurses. It's my personal choice. If it requires to keep them at your house, if it requires one of you to quit your job, you do that. That's what I do. So we said, no, you're coming here, end of story. So I had no problem getting up 6 a.m. I took her blood, checked all that, blood pressure, everything else. I left to go teach. My wife would make her breakfast and such, but it was interesting. My mom would say, I want an egg, no runny yolk, and 6 grapes. And so you start to think, well, why would you ask for 6 grapes? What I found out dealing with older people over the years is that they look for senses of control in every possible and feasible way. So if they ask for something specific, it's the little bit of control they're trying to retain. You don't question it, you give them that, right? Especially like the foods. Now, I don't know what your ethnicities are, but if you're used to ethnic foods, you never know what life's going to be like in 60 years from now if you're going to have access to those. So, my mom, she was full Italian. So I remember my wife calling me at lunch and saying, my wife couldn't pronounce it, something like she wants, I don't know, it's a foyer free. I said, foyer frite. It's fried greens, just olive oil and garlic. I said, well, tell her I'll be home in a half hour and I'll make it. So you wind up having control. This is such a high level of dignity that we all want to retain, that if it seems like we're pushing the limit on capacity with lowering the threshold to the point where maybe this is not in their best interest, in their medical interest, remember that somehow the person comes first. And as long as they are determined to have their own decision-making capacity, and even if what they're trying to determine for themselves is not medically rational, medical rationality for a procedure is not the threshold, okay? It's functional capacity. So we have to keep that in mind, okay? Anyway, any questions on these? You guys are being easy on me. Okay. Now, I picked an emergency room here because just like when people come into the emergency rooms and you have to imply that they are going to consent to a procedure, you're also going to imply that they have the capacity to consent, right? So that's all on that, because the reality is that it, you you're trying to work to preserve their life. That's the first thing. You're trying to reduce any suffering. You're trying to minimize any injuries that they have. You're just treating the illness or whatever it is, the injury that's come into the emergency department. And the reality is that um, even if the person, just like, consent, if a person came in off a motorcycle accident and started, trying to not consent to very basic things, then you don't really have to follow that, because the person may not be in a state of capacity where they're making determinations. In other words, there's like some basic things that are going to have to be done for life-saving procedures, and they're pretty routine. And you can't just assume that the person is not in shock, and there's no way to assess the individual. In other words, it's not going to be enough to simply ask them if they know who they are and where they're at. Those things are perfectly fine, and we'll talk about that in a second. But there's going to be other issues going on. So the reality is you want to stabilize the individual. If we're going to try to determine afterwards the level of capacity that that individual has and whether or not they are able to and make their own decisions, that'll come later, but not when you're in the heat of the moment. So as a nurse, you're always the advocate for the patient. On everything, and that is a bigger duty and responsibility, I think, that you can appreciate it. It might seem like minimal, like we're not making the determinative, calls on capacity, but you're advocating. And in the other case, that this person is either lacking capacity or is in a diminished state, or maybe you're trying to determine it. It's almost as if somebody is there and has their back, and it's the nurse. And that's by your code, right? You have to advocate for them. So you're always there to protect them. You're always to make sure that whatever is going on, they're absolutely safe, and that their rights are always being upheld. It's not that a physician is going against that. It's just that there are times where you're closer to the ground, and even if a physician in the past or in the future, where they might have medical paternalism, then a nurse will step in, okay, and at least through an advisory or such. Whatever forms you're filling out as individuals coming in, you'll probably put down the nature of the injury so that it is severe. And when it comes down to filling out the consent, you of course will fill out implied consent, because that's accepted, especially in severe injuries. And again, you can imagine people that come into to the emergency department. They could be intoxicated. They could be on drugs. They could be, gunshot victims. I mean, all kinds of things. They could be in shock. Who knows? So there's going to be a lot of things going on very quickly and very fast. I'm curious, is anybody here interested in going into emergency care? You are, Brenna? Okay. I was friends with a nurse. She's now a school nurse, but she did, I think, like 7 or 8 years of emergency care. She loved it. It does take its toll on you, but it goes, right. I mean, it has to go in and out at these times. So nonetheless. Okay, again, it's not a switch, so capacity is going to be rather dynamic, and it's going to have to be vigilant. You're going to have to be vigilant keeping up with it. So it's always, again, just to reiterate, it's always implied, especially when it's impossible to obtain. You're just going to assume that the person is going to be able to they would have the capacity, and that you're going to take the consent based on the fact that it's an implied capacity. This last part, before we get into any last questions and we do our case study, is that there's always what they call the yayo times 3. So is the person alert, and are they oriented times 3? So is it person, place, and time? Now you have to be careful here, right? It's very easy for a person to get their date screwed up. So that would not be sufficient in itself. Even to get the year wrong. Sometimes you see, what president is. But if the person knows who they are, if they know kind of where they're at, if they know, like, if there's family around, then well, that's my son, that's my daughter, that's my wife. If they realize that they're in a medical facility, they might get that wrong. They might think I'm in a clinic. They might not know it's an emergency department, but that's not so much the case. These are all things that will be asked regularly. So I was talking to my wife before class today, and her grandfather, he's passed on now. They called him Paw Paw. Did you remember when your Paul was in before, even the last few weeks of his life, they would come in regularly and ask him questions. What's your name? Where were you born? Do you know what year it is? Do you know what president was? But he was pretty slick. So what he would do is and whatever question they asked him, he would write the answers on his Kleenex box that was sitting right on like the table that straddled his bed. And he assumed that the next time they came back in, they were going to ask him the same questions, and he'd be able to pick up his Kleenex box and answer them again. But they never did. So he was always trying to outwit them. But just the fact that he was doing that, even though if he was disoriented, right? He knew who we all were. He knew what he was doing. He knew that he had picked up MRSA and that this was not good. He understood all these things. So even if you got some things wrong, I'm not sure what day it is. That's to be expected, especially, again, you think of how we're in these, only 3 weeks of lockdown. And if you don't have a very tight schedule, sometimes in the morning I ask my wife, I said, now, wait, is this Monday or Tuesday? I'm figuring what classes do I have today, that type of thing. So it's very easy, but nonetheless, AO times 3 is at least the basic method that they would use. Start filling out whether this person has some sort of capacity issues. Any questions on that before we move on? Then at the very end, I have a real short follow-up on a question that another student asked in another section. You might be interested in it. Okay, so we're going to do our case study. So if you can get out your phones. What we have here is we have an elderly man, and he fell, so now he's being evaluated after his fall. Now he has coronary artery disease, hypertension. He has non-insulin diabetes, beginning of dementia. He's got kidney issues. Well, his wife passed away 7 years ago. He misses her, and he doesn't really enjoy the physical limitations that he's in. We all won't like that. He's been residing in an assisted living facility for the last 3 years. At the hospital, he's with his niece, and his niece seems to be around him regularly. So she's there ever since his wife passed away. Can't really trust her, almost like, confides in her. So he's alert and he's oriented to person. He knows who he is. He knows, who his niece is and such. He thinks he's in a clinic. So he's not really quite sure that he's in the hospital. He doesn't know where he's at. And he doesn't really know the current year per se. So those are just two factors. But everything else is pretty much unremarkable. I mean, there's no reason to, raise any flags. So his niece says, look, my grandfather's not very fond of medical care. And he only goes when it's absolutely necessary. So unfortunately, all his labs are from 2 years ago. So his high potassium and his blood and nitrogen and stuff, not doing well. Dr. Hawkeye Pierce. Now I have to ask, I know I'm much older than everybody here. Has anybody ever heard that name, Dr. Hawkeye Pierce? Anybody ever hear of the sitcom MASH? Okay, you got to go on one of the upper channels on your cable and watch MASH from the 70s, early 80s, probably one of the best sitcoms that ever came out. Dr. Hawkeye Pierce is one of the guys. All right, so I had to throw that out there. I don't like to say the position. Anyway, so the physician talks about long-term need for dialysis with this patient and the niece. And the patient says, no, I'm not doing it. I'm not going to an old folks home. Well, that wasn't quite what they were saying, right? He needs dialysis, but he may not be totally off. He's probably not going to be able to allow the return to assisted living. He's probably going to be at the level of nursing care at this time. Although in my experience, sometimes in assisted living, you have people who need nursing care, but there's no opening. So they leave them there and they're a little undertreated until an opening shows up. That's aside, right? So he tells the physician, look, I'm fine with my medical condition. And his niece is even vouching for it. His niece is like, yeah, he's good, right? But he also thinks this is 1988. So now they're wondering, okay. So the question I have for you is, given what you've had, don't overthink it. Is it safe to assume at this point that Hank has the capacity to make decisions, even if you need more information? It's not saying you have everything. But do you think he has the capacity to make decisions at this point? Or would you say he lacks capacity and somebody else just, now make decisions for him? Okay, I would go with A, and only because I understand that it's mitigated But remember, if a person will be declared incapacitated, you're no longer going to allow them to make decisions on their own. He's not quite there yet. Um, it is true that it doesn't quite have the year right. That's a little concerning, but it's not enough on its own. It is a little concerning that he thinks he's in a clinic, but if he would have said I'm in, I don't know, CHOP, would that make a difference? I mean, he may not know where the ambulance took him. Especially if you're in assisted living, the ambulances just show up to these things, put you in it, and off you go. You may not be quite sure exactly where you're going. You're laying down in the back. So it's a concern, but remember the threshold's very low. And so in other words, it doesn't take much to meet it. Think of like jumping over, you know, I don't know, some sort of stick, and the stick's held very low to the ground. It doesn't take a lot. That's how it is with capacity. Okay. It doesn't take a lot to make sure to say the person has capacity. All right, so let's continue on with the decision a little bit. So Pierce explains to Hank, look, you're going to need care beyond your assisted living arrangements. You're not going to be able to stay there. You need dialysis. Following the patient's declaration that dialysis is not something they're interested in, his niece says, look, my uncle's a minimalist when it comes to any interventions. So Lydia, the niece, explains that her uncle had similarly refused cardiac catheterization back in the 90s. So here he is, 20 years later, and he's still kicking. So Dr. Pierce reviews with the patient, the niece, and he says, well, dialysis is going to be the only procedure to replace his failing kidney function. And failure is, this is not going to be compatible with life. So eventually it's going to result in death, particularly because he doesn't have any other terminal illness. Yes, he has coronary artery disease and he could have a heart attack and die, but that's not a terminal illness. So, so if you don't do anything, this will be the thing that kills you. It's not like there's something else out there waiting. So they consult a nephrologist and reviews the recommendations with the patient and the niece. And the patient just refuses. I'm not doing it. So having clearly communicated his choice, you ask the patient if he understands the situation. This is one of the components, right? He's able to articulate it back in his own words. That's one of the things. My kidneys are failing. That's how I have the high potassium. So you say, well, do you know what that means? Yeah, it means they're not functioning and they're not going to do much longer. And I could die from that, right? I mean, you will die, but at least gets that much. So Hank's physician, I'm sorry, Dr. Hawkeye Pierce calls in some sort of, no, looking ahead. Hank's decision not to pursue life-saving treatment seems irrational, especially considering he suffers from no other terminal illness. Is Hank clearly lacking in one of the four components in determining capacity? So, again, I'm giving you a heads up, think low threshold, right? Because it's very easy for us to want to insert paternalism here because it seems like he's not being rational, medically rational, which if I would ask that question, is he medically rational? I would say, no, he's not. But we're trying to determine whether or not he has capacity, right? Yet no is right. He's able to talk about the causal link between his decision and the outcome. He's not like, in other words, he's not saying, look, I have no problem. I don't need dialysis. Who knows? Maybe in a few years I'll get better. He's not talking like that, something that would make you think he doesn't appreciate the level of disease that he has, right? So all of this is, at least he recognizes what's going on. It seems like he demonstrates sufficient capacity. Again, you may not like a decision, but it's a low threshold. Okay. Now, let's just switch it around a little bit. In this one, we may have to have a little discussion follow up with. If Dr. Hawkeye Pierce calls for an ethical consult, and the following psychiatric evaluation finds his position refusal to fall within the threshold of incapacity. Now, they're not going for legal, competency, but they've declared him that he's incapacitated. He doesn't have mental capacity for this. Do you think they can still ethically force him to do this? And you can go both ways on this, but one of them is a better answer. And another one, you would have to give me a very good reason why you chose that. Well, I'm going to guess everybody's going with B, and that's correct, right? You'd almost have to wonder, like, go back to Pandora. Could you imagine if you forced her into dialysis? Now, dialysis isn't like a one-time thing, so you could, I guess, conceivably stop it in the future. But if she was already concerned about being a burden on our own children, well, that's just going to, magnify that, right? So if this individual, again, this dialysis is going to require him to go on a regular basis. We don't know what support he has. His need shows up, but who else is there? We don't know that any brothers or sisters or what's his financial situation's like. No, I realize I didn't give you a lot of the circumstances, but you have to start asking, what is this going to psychologically do to Hank? And then what's the pragmatic view of this? How would you do this? I mean, now if he's, they're not going to be able to do this per se in nursing. Are they going to have to like transport him on a regular basis, or will they have the facility, and perhaps the nursing facility is hooked up to a hospital and they could just wheel him down the hall? It's hard to say. But all those things would have to be ethical considerations. So some of the other students in the first section said, well, no, I still would go with yes, because there's life there. Well, you would really have to, with dialysis, maybe you can make that call, because you'd have to like be very concerned that if you declare this person with lacking capacity, that they don't get locked into an endless loop where they can't make a decision down the line. Now, this isn't the same thing as legal incompetency, so perhaps this could be brought back. So maybe you could say we could start you out, with dialysis, and then after 2 or 3 weeks, reevaluate your capacity, and at that point, then follow through and withdraw. But then you'd almost have to ask yourself the question, what's changed? I mean, if the same reasoning is going to happen in 3 weeks than it happened, right in the beginning, then are you really just prolonging this and causing psychological grief, or otherwise you wouldn't have to. So, we would need a lot more circumstances, much more consult and ethical consult involved with this to really determine what's going on. But no is the safer answer. Okay. Any questions on any of this? Um, I want to share one thing with you, because